Good afternoon, everyone. Thank you so much for joining us this afternoon. My name is Julie Herdlicka, and I have the great privilege of introducing these incredible speakers this afternoon to talk to us about Alberta's drug poisoning crisis and how do we get here and where do we need to go. First off, we're going to have Heather Morris speak. Currently, Heather has just started a new position as an assistant professor in the Faculty of Nursing at the University of Alberta, and she's going to lead off the discussion this afternoon.
Well, thank you very much for that introduction. And I want to begin by respectfully acknowledging that I live and work on Treaty 6 territory, traditional lands of First Nations and Métis people. My name is Heather Morris. I've been studying substance use and harm reduction, drug policy advocacy by bereaved families, and public opinion of harm reduction for about a decade now. And I want to acknowledge the other co-author on this presentation, Dr. Elaine Hishka, who was my PhD supervisor for 6 years. And also co-author, as I mentioned, on this presentation. And I also want to acknowledge two organizations that I've worked with, Mom Stop the Harm, Patriot Schultz in particular, as well as Boyle Street Community Services for partnering with me on my doctoral work, and most recently on my postdoctoral work that was supervised by Dr. Janetta Salvalaggio in the Faculty of Medicine. So the intent of the talk that I'm going to be giving today is to outline very broadly the situation that we're in, how we got here, and also what it could ultimately take to bring down morbidity and mortality. And I'm going to try to do this in the next 25 minutes or so before turning things over to Marliss Taylor, who is another one of my mentors. So just a short outline for today's presentation. I hope to touch on the following. First of all, we'll talk about epidemiology of drug poisoning in Alberta and Canada. We'll talk about how did we get here, as well as responding to the drug poisoning epidemic. So what works, what doesn't work, and where do we need to go, what is worth trying. So let's start with epidemiology of drug poisoning in Alberta and Canada. The stats that I'm about to review represent real people whose deaths were preventable. Many of those who died are young and middle-aged people who leave behind parents, children, siblings, partners, and they are very much missed. The overdose epidemic, or more aptly, the drug poisoning epidemic, is one of the greatest public health issues of our time, and it is historically unprecedented. And a particularly sobering thought is that Stats Canada reported that in 2017, the life expectancy of Canadians did not increase for the very first time in more than 40 years, and this is largely due to the drug poisoning crisis. Between January 2016 and March 2023, there have been over 38,000 apparent opioid-related deaths across Canada. And at the moment, this equates to about 21 deaths per day. BC, Alberta, and Ontario have been hardest hit when it comes to the highest number of overdose deaths. However, Saskatchewan and Yukon are also showing very, very high rates per 100,000 population. We know that most of the deaths are among young and middle-aged adults, 20 to 49 years of age, and 3 out of 4 who have passed away were male. Currently, 81% of accidental apparent opioid toxicity deaths in Canada involve fentanyl, and we'll talk a little bit more about that shortly. Now, the Alberta Substance Use Surveillance System recently updated its dashboard the very first week of November, and it was showing that 1,512 deaths in 2022. And then furthermore, in the first 7 months of this year, 1,262 Albertans died from an apparent accidental opioid poisoning. So we are very much on track for possibly the deadliest year on record here in Alberta. Beyond mortality, opioid-related morbidity is also high in Canada, and it places a very significant burden on our healthcare system. So Alberta is third for opioid-related hospitalizations in Canada, with an age-adjusted rate of 20.0 per 100,000, with the national average being 17.4 per 100,000. And the top figure here shows EMS responses in Alberta by week hit record highs over this past summer. So many of you might recall in the media the stories about many calls out for ambulances and so forth. Now, the figure on the bottom describes for us the location of unintentional opioid poisonings deaths in Alberta, and what is significant here is that there's been a shift from 2018 from being primarily private residences in terms of where people passed away to today being almost an even split between private residence and public location. Now, as bad as these mortality numbers sound, they're likely underestimated because in both Canada and the US, drug-related deaths are poorly classified. And a recent study in the US that looked at this issue estimated that the actual death count from illegal drugs each year may be 2.2 times higher when accounting for other related conditions and causes of death. So how did we get here? Research has shown how the overdose epidemic in North America has more or less unfolded in three overlapping waves. And the first wave is probably most well known to people and understood because of quite a bit of information that came out in the popular media around this. So multiple new pharmaceutical opioid treatments were developed and heavily marketed as safe and effective for treating chronic pain. New products advanced using highly questionable marketing techniques and practices by actors in the pharmaceutical industry. And then prescription opioid demand was also facilitated by a number of factors, including obesity, work-related injuries, increasing social isolation and psychosocial stress, as well as a renewed emphasis on treating pain. So by 2010, more than 1 in 20 adults and as many as 1 in 6 adolescents in Canada reported using prescription opioids for non-medical purposes. So in response, starting at around 2012, officials both in the US and Canada implemented new constraints on prescribing and dispensing that were designed to curb the availability and potential diversion of prescription opioids. So in Canada, what happened, multiple provinces delisted oxycodone from their drug formularies, and most jurisdictions implemented or strengthened prescription monitoring programs and increased regulatory oversight over opioid prescribing practices. But much to the surprise of many, efforts to suppress prescription opioid availability did not lead to a decline in deaths, and instead the annual number of opioid overdose deaths increased across Canada and the US. So there's evidence of a concomitant rise in heroin use and related overdoses in both the US and Canada, starting at around 2010. And this was attributed in part to expanded pool of susceptible users who initiated opioid use via diverted or prescribed pharmaceutical opioids, and then they switched to cheaper and more potent street drugs. And then the second wave was the first indication that gaps in the prescription opioid supply were being partially addressed by a rise in street drug use. Now, ultimately, the availability of heroin on the illegal market was not sufficient to fill supply gaps left by a dramatic decline in the diverted prescription opioids circulating, and it was around 2012, 2014 when we started to see novel synthetic opioids gaining ground in the illegal drug market. So synthetic opioids, examples being fentanyl and carfentanil and so forth, cheaper and easier to traffic relative to heroin, and we're thus better positioned to fill this consumer demand. So not a sudden jump in the rate of opioid disorder around 2012, 2014, opioid use disorder, I should say, but rather what we saw was a fundamental shift in the illegal drug supply that has made opioid use more dangerous. Whereas people before may have used opioids non-medically, perhaps aged out or naturally recovered or sought treatment, some now are not getting that opportunity because the drug supply is so dangerous. We've also observed a growing fourth wave of psychostimulant co-use, and many people report co-use of stimulants as one strategy to balance sedative effects of the unpredictable and potent opioid drug supply. So in our recent study, where we interviewed over 500 people who use drugs in Edmonton's inner city in partnership with Boyle Street Community Services, we had a number of people explain to us that they would, for example, take meth to counteract the sedative effects of the down that they were taking, and they thought that this, in fact, made it safer for them, when in fact we know that it actually increases your risk. So going back to the stats that I shared initially, 48% of Canadian accidental apparent opioid toxicity deaths between January and March of 2023 also involved a stimulant. So multi-drug toxicity is very much a contributing factor to this crisis. We used to call it the fentanyl crisis, and we called it the opioid crisis, and now it certainly is a drug poisoning crisis. And then finally, an additional complication to substance use treatment and opioid poisoning response is the contamination of the illegal drug supply with benzodiazepines. Many of you know that benzos are used for sleep or anxiety disorders. They're cheap, they're easy to get, and added as fillers. And this increases your risk of overdose because it increases your risk for respiratory depression in the same way that mixing down with alcohol would. And then the other thing too is that overdoses that do occur are harder to reverse with naloxone. So originally we may have seen people be able to respond to naloxone after 1 or 2 ampules, and now it can take many, many ampules before they were able to come out of that overdose. So I want to just also emphasize there are many, many other very significant reasons for the drug poisoning crisis. One significant reason is that people take drugs oftentimes to help them cope with the emotional pain that is associated with either current trauma in their lives or past trauma in their lives. Sometimes people take drugs in order to help themselves feel better if they have an untreated mental illness. So there are a lot of people that are suffering right now, and that needs to be recognized. Other contributors include stigma that is associated with taking a criminalized drug. For a lot of people, they're sometimes afraid to go and ask for help because the drug that they're taking is not regulated, it's not legalized, and they carry shame or embarrassment, and so that prevents them from seeking help. Poverty and lack of affordable housing, structural racism, lack of access to appropriate health services. These are all examples. We also know that there is no doubt that the COVID-19 pandemic also played a significant role in increasing morbidity and mortality as well. And this is due to a number of factors. First of all, increased isolation and stress during the pandemic, which affected all of us, but certainly can increase your risk for using substances alone. A disrupted supply chain with the closure of the US border, which many believe led to an increasingly toxic drug supply. And then thirdly, a decreased access to community supports at the height of the pandemic as well too. So the contaminated illegal drug supply is a public health emergency. How should we respond? Well, first of all, it's important to recognize that most people who use opioids are not seeking formal health care for opioid use disorder. Many people who use drugs are at risk for drug poisoning, but don't have a substance use disorder or need treatment, and many others may meet criteria for opioid use disorder, but do not perceive a need for formal care. So we need strategies to address risk across the entire population. And evidence supports a range of harm reduction and treatment interventions for preventing drug poisoning deaths. So I'm going to now review some of those. Multiple systematic reviews support the effectiveness of community-based naloxone programs. They produce long-term knowledge improvement regarding opioid overdose. They improve participants' attitudes towards naloxone. They provide sufficient training for participants to safely and effectively manage overdoses. We know that they reduce mortality, and they're also cost-effective. Supervised consumption sites or supervised consumption services. These are facilities where people consume obtained illegal drugs. They're monitored for overdose by healthcare providers who are present, and oftentimes at these sites they also provide wraparound services on site as well too. So Insight was Canada's first supervised consumption site. It opened its doors 20 years ago, September 21, 2003. They were kind of the only shop in town for a long time, and then in 2016, when the federal Liberals came into power, we saw an expansion of supervised consumption sites, and so I think there might be in the low 40s or so in terms of the number of supervised consumption sites across Canada. So research shows that they reduce overdose mortality, they reduce syringe sharing, they reduce publicly discarded syringes, they reduce public drug use, they facilitate treatment uptake, they also save money, and they do not cause an increase in neighborhood crime. And a recent study from Vancouver also showed that regular SCS use is associated with reductions in all-cause mortality. Now, unfortunately, the policy and services related to SCS use here in Alberta are going backwards instead of forwards. We know that Alberta canceled 2 planned SCSs quite a few years ago that were planned for Calgary as well as in Medicine Hat. The government has reduced SCS capacity in the city of Lethbridge as well as here in Edmonton. They announced plans to close the present Calgary SCS and replace it with 2 smaller SCSs, but that is still in limbo, so there is still some uncertainty around that. As of 2022, SCS clients are required to produce their provincial health number, which for some can certainly contribute or act as a barrier for access to this service. And the other thing too is that no SCSs at the moment in Alberta allow for smoking. And in the study that I mentioned before, where we interviewed over 500 people who use drugs in Edmonton's inner city, the majority of people told us that their preference was to smoke their drugs. And so you can understand, obviously, that, that without allowing for smoking at a supervised consumption site, that this is a problem that likely very much needs to be rectified in the future. So one bright spot is the announced funding for the new OPS, or overdose prevention site, that is off White Avenue. There has been some community opposition, which has been in the news, and Marliss will probably talk about that about the new OPS in her presentation. So opioid agonist treatment is an important part of the solution here. It cuts mortality risk in half, and it is considered the gold standard of care for opioid use disorder. So examples here are Suboxone, methadone, Sublocade, as well as Cadian, which is a slow-release oral morphine. There's also injectable hydromorphone, which is offered at IO clinics and so forth here. Most receive opioid agonist treatment on an outpatient basis. The care is involved. It involves stepped care with varying treatment intensity as well as health system integration that includes facilitated access to psychosocial and socioeconomic supports as well too. We need treatment to be as easy as possible to access and available where people present for opioid-related care, and these include emergency departments, hospitals, doctors' offices, but this doesn't always happen, and particularly in some of the more rural communities. Alberta has significantly expanded oral opioid agonist treatment access since 2016. Alberta also provides gap medication coverage for those without benefit plan. And we've also seen next day virtual access in many communities increase over the years. So those are all positive news stories. But we've also seen limited access in provincial jails. Population coverage is still low. Also, the Narcotic Transition Services regulations, which I referred to before, one of those being that people have to now present their provincial health card number to access some of these services. These can pose significant barriers to people who use drugs who are trying to get help. I also want to emphasize that it's important to note that short-term detoxification and/or residential treatment by itself and separate from the medications that I've just mentioned have not been shown to be effective for opioid use disorder and may in fact increase your risk of overdose due to the high risk of relapse following a period of abstinence associated with program completion. So this is a 2020 JAMA open study out of the US. Researchers looked at outcomes following 6 mutually exclusive treatment pathways, including residential treatment and inpatient detoxification. Only treatment with opioid agonist medications reduced the risk of morbidity and mortality for opioid use disorder at both 3 months and 12 months follow-up. Now, emerging body of evidence also shows that drug checking can alter individual behavior. It can also be a valuable tool for monitoring the illegal drug supply as well too. At the moment, Alberta doesn't fund drug checking services, but there is one grant-funded Health Canada drug checking program currently in place in the city of Calgary. It's a mobile van that is operated by AWARE, or the Alberta Alliance, who educate and advocate responsibly. And finally, I just want to say a quick word about hospitals, which have traditionally been seen as being unhospitable or even a risk environment for people who use drugs for a number of reasons. If you think of somebody who uses an illegal drug regularly and they come into an acute care hospital and now they're in a room with 4 other people, they may decide to go into a bathroom, lock the door, and that all of a sudden has increased their risk for overdose because people can't get there to help them when they need it. Also, there's risk of increased likelihood of leaving the hospital before discharge is recommended, as well as a risk of unsupported withdrawal when you come into the hospital. Research has also demonstrated that patients who use drugs experience discrimination and substance-related stigma from the healthcare providers who are supposed to help them. My oldest daughter, who is a nursing student, just commented to me, she's in BC, and she just observed this the other day in the emergency room where she's working right now. So a group of healthcare providers at the Royal Alex, led by Dr. Catherine Dong, an ER physician, decided to do something about this in 2014. They created the Addiction Recovery Community Health, or ARCH team, and this is a multidisciplinary in-hospital consult service as well as a transitional outpatient clinic, so that when somebody comes into the ED at the Royal Alex Hospital, or if they're admitted to the hospital and they have active substance use or a history of substance use disorder, they can be seen by a member of the ARCH team that can provide a number of different services and supports to them. So this is pretty unusual. This type of program is not offered in most hospitals. And I also want to add to a proud plug that the Royal Alex has the first federally approved hospital supervised consumption site for inpatients in all of North America. So that's something to be proud of. We need to bring what works to scale, but we also have to be willing to try new solutions to save lives. Decriminalization is one such example. To decriminalize the personal possession of drugs, the Federal Minister of Health has to provide an exemption from the Controlled Drugs and Substances Act on public health grounds, And while this still isn't being done countrywide, it is being done in the province of BC. So basically, they received an exemption for the entire province starting January 1st of this year. And that exemption is to last for a period of 3 years, and decriminalization is being evaluated as well as we speak. So it isn't legalization, but in fact what happens is an adult who has 2.5 grams or less of a certain illegal substance on them won't be arrested, charged with possession, and they're not supposed to have their drugs taken away by police either. A second really important policy option that is on the table at the moment is safe supply. And safe supply is defined as a legal and regulated supply of drugs with mind-body altering properties that traditionally have been accessed or accessible only through the illicit drug market. So I want to emphasize this is not treatment. This is basically giving a safer form of what people would purchase illegally on the streets to people who want it. Why is this being considered? Well, the illegal drug supplies I've already mentioned is poisoned with fentanyl and fentanyl analogs and other substances. Not everybody wants to receive treatment for substance use. Medications like methadone or Suboxone don't work for everybody. Only a portion of people who use drugs will be able to access services like supervised consumption sites, and these exist really only in major, larger cities as opposed to some of the rural areas. So the federal government opened its doors to safer supply in March 2020 when they created new rules that allowed pharmacists to provide controlled substances to individuals for the purpose of harm reduction. And then BC also developed its own guidelines around the same time in response to the pandemic. So pharmacists, nurse practitioners, nurses, and registered psychiatric nurses can prescribe safe supply depending on where you work. The most common prescribed safer supply drug would be Dilaudid or hydromorphone pills. And in terms of the research, promising outcomes are beginning to emerge from a number of recent studies evaluating low barrier safer supply programs in Canada. So some examples would be high client retention, declining mortality risk, declining ED visits, hospital admissions, declining healthcare costs, lowered levels of injection drug use as well. So if any of you are interested in seeing some of that literature, please come and talk to me afterwards. So while these medical models are well-intended and likely to generate important health outcomes at an individual level, their population impact is limited by the fact that they are able to engage only a small number of people who are at risk of overdose. So in BC, less than 5,000 have been connected to pharmaceutical alternatives through their provincial program. A major limiting factor is a reluctance on the part of prescribers to care for this patient population with conventional substance use treatments, let alone prescribe them psychoactive substances for non-medical use. Programs also struggle with space and ensuring enough staff to dispense medications and offer individualized support to client populations with a high degree of complex needs. So this is a quote from Benedict Fisher. The current opioid crisis in Canada would require systematic identification and protection of as many as 1 million users at risk from toxic opioid products through provision of a safer supply. When I first read that, I was actually completely shocked. And then I don't know if any of you went home last night after the talk by Avi Lewis and watched the National. And there was an episode there where they were talking about safe supply. Dr. Lisa Lapointe, the chief coroner for BC, they were interviewing her. And they mentioned that 225,000 British Columbians are at risk of dying every day because of using unregulated drugs at the moment. So that was shocking. That's almost 250,000 of people just in one province alone. Finally, we can't ignore the need to address upstream drivers for demand. This would include improved management of chronic pain and addressing underlying social structural determinants of health, so colonization, poverty, housing insecurity, mental health, evidence-based universal prevention programs for children and youth as well. And it's also really worth mentioning that many of these investments would pay dividends in many realms of social life, not just in the area of substance use. So to conclude, drug poisoning is a major public health problem. Fundamental and likely irreversible changes in the illegal drug supply are driving a surge in morbidity and mortality. Deaths are preventable, but require a fundamental shift in how we address illegal drug use, and the public health response and resources should match the disease burden. So thank you so much for listening. I'm going to turn things over to Marliss right now, and then maybe what we'll do is we'll take questions at the end after Marliss's presentation. Thanks for listening.
I am always delighted to share the stage with Heather, but you need to know I'm a bit less genteel. I've been a nurse in the downtown core now for 28 years, and I'm tired and fed up with what it is that we're dealing with these days. So if I swear a little, please just forgive me. What am I going to just mention? Just a few things, some issues that are contributing to the record number of drug poisonings, a bit about recovery and harm reduction, some myths about the drug poisoning crisis, the interplay between the drug war and environmental issues, and then look at some of the current programming and possible solutions. So what are we seeing on the ground? My team, the Streetworks team, and I, and any other nonprofit worker in Alberta, I think, we were just seeing an explosion in the toxic drug supply. People don't know what they're getting. It's a toxic soup. And I have to say, there's a different interpretation. My interpretation of the history of the drug poisoning crisis that we're in right now, certainly the Sacklers, and there was, over-prescribing, I guess. That's not what we saw downtown. What we saw downtown were people taking pills where they knew exactly what they were, they knew the dosage, they knew exactly what it was. It was always peaches or grays, which are types of morphine. That was the street name for the morphine, and a few other things. Once 2012, April 1st, when OxyContin was taken off the market, that's when we started to see a real increase in this toxic soup that we're dealing with right now. I think a lot of people tend to see illicit or criminalized drug use as why are people doing it? Well, there's lots of reasons. It keeps people alive. If people cannot get the help that they need, if this will keep you from jumping off the bridge tonight, then I want you to take it. If that's it, we'll work on more stuff tomorrow. But that's sort of where we're at in some ways. It's around managing people's life challenges. If you think about it, because I would challenge anyone here to be in the situation that we're seeing in the downtown core of Edmonton right now. If you're in a tent that was just taken away by the authorities, it's -20, you've just been beaten up, you have to stay awake because you managed to hang on to some of your possessions, you have to walk all night long, you have no place to go, the shelters may be full, or it may be that you can't get in there because you have a dog, because you have a partner, because you were barred from something that happened a while ago. It's very difficult to get through that sober. It just is. People use these substances to feel better. If you're using stimulants, they make you feel smart and strong and beautiful and important and energized and able to handle the world. And when your life is crap, that's what people do. The down drugs, the opioids and the benzos, they bring a sense of peace and decrease anxiety, and a sense of love, actually, is one of the words that some of our folks have used with me. And it's also, so why don't they just use alcohol? Well, because you can't walk around with a six-pack downtown, period. You have to be able to hide it somewhere in a pocket or in something. You owe people. People will take it. And so having legal substances makes it very, very difficult. What is recovery? A return to normal state of health, mind, and or strength. These kinds of programs, certainly, they could be medication assistance, they could be residential, they could be 12-step kinds of programs. The goal being abstinence. Actually, I worked with a gentleman years ago, an older gentleman, he was probably 70 so, and he had a dependency on crack. And so we worked together, and he ended up going into a 12-step program, and for him that worked, and I was really happy. And what he said to me later was, Marliss, here's what I'm wondering. They say you have to hit rock bottom. He said, but what if you start at rock bottom? And that's what that kind of means, the return to normal state of health, mind, or strength. But a lot of the folks that we're seeing already started 10 miles behind. What's harm reduction? We're trying to keep people as safe and healthy as possible, depending on high-risk activities, and we're not requiring that you are abstinent. Are necessary. I don't know anyone in harm reduction who does not support recovery programs at all. But you have to get there, and there's lots of barriers for people, and so we want to not just keep people alive, but also help them build up the confidence in their own feeling of self-worth and having respect, because you kind of need that before any of us are going to take a big step in our lives. Heather made the point, and I'm going to say it again, not all criminal drug use is addictive, and that tends to be the story that we have right now. So I'm going to challenge that a little bit as well. So we know physicians used to prescribe substances. You actually used to send stuff to people in World War I on the front line that had a number of substances and actually some needles in them. Off that went. You used to be able to buy things in Sears downtown. You could buy cocaine, for example, in the 1940s. These are not new issues. HIV came along, that changed the game because as people got smarter and did the research, we discovered that, of course, blood to blood is the easiest way to transmit HIV. And so a number of European countries and Australia said, this is a bigger risk to us. HIV is a bigger risk than drug use to the population is. But here's where our moral outrage comes. And I mean that because we have moral outrage against some drugs that have been deemed illegal, but we're okay with legal drugs. The US in 1971, June 20th, actually, Richard Nixon declared this war on drugs public enemy number one. And in 1984, Nancy Reagan said the problem was that young people just don't know how to say no. But there's a backstory to this, and it's an important one, and I think a lot of people don't realize this. This came from John Ehrlichman, who many will remember his name. The Nixon campaign in 1968, the Nixon White House had two enemies, the anti-war left and black people. Do you understand what I'm saying? We knew we couldn't make it illegal to be against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about drugs? Of course we did. And that set forth, now we have had 52 years of a drug war rooted in misinformation and stigma, and I think this is where we found ourselves with this. Really quick definition on harm reduction. I'll just tell you ours. There's a number that are out there, but Streetworks made our own. It is a comprehensive, just and science-based approach to substance use, and the principles can pertain to things like sex work. I don't say it's a baby car sake, but anyway. It represents policies, strategies, services which aim to assist people who use legal and illegal psychoactive drugs to live safer and healthier lives. Harm reduction recognizes that people use drugs for many reasons. Reduction of substance use and/or absence is not required in order to receive respect, compassion, or services. Policy and practice must reflect these realities. Harm reduction enhances the ability of people who use substances to have increased control over their lives and their health and allows them to take protective and proactive measures for themselves, their families, and their communities. We're looking at evidence from science, but also from lived experience, from people who are out there on the streets. We're going to talk about compassion and justice, and we're going to challenge stigma and discrimination. We're going to include the meaningful and active involvement of people who use substances. And we're going to recognize, of course, there are positive and negatives for any substance, but that includes our legal ones as well. We're going to look at policies and laws that are creating these risky environments. I'm flying through this one really fast because I want to get to more stuff after. We're going to recognize that if we regulate substances, we're going to decrease costs to health, justice, and social systems, decrease violence, increase access to prevention care, treatment, and support services, decrease barriers for people, decrease racial profiling, and respect the human rights of people who use substances. I think that's all just so critical. We're going to be creative, and we're going to be pragmatic and cost-effective and sensitive to the available resources, the social context, and personal history of individuals. We have to be courageous and think outside the box. At some point, we have to say, this hasn't worked for 52 years, or maybe we should try something different. But it really does not seem to be a point of courage for the general public. I don't see a lot of courageous steps being taken out there. And I do think that there is also a group or groups that are pushing back really hard right now against thinking outside the box and trying something differently. We're going to promote thoughtful, balanced, and well-researched approaches to the actual harms of substances and give truthful drug education. We lie to young people all the time. Anyone that went through the DARE program would have been lied to at some point. And some of that comes back to 1971 when the Controlled Substances Act came in. Part of the rule was that you could not do research on an illegal substance and show any positive impact from it. And I think, so then all of us have been schooled for 52 years in only half of the story. Some of these drugs actually make people feel good. They actually help them. We're going to advocate for enhanced and effective treatment options. Our folks that we send off to a treatment program, we do it with crossed fingers because the chance of overdosing when you come out, we know that a substance use disorder is relapsing. What I will say is that those of us who are involved in harm reduction, we're not trying to make it worse. We're not trying to enabling harmful drug use. We're actually, what we know is that when people can be honest with you and not have to hide their substance use, can give you the actual story on what's going on with their lives, you are way more likely to be able to help them access the services that they need. They can't do that if they have to lie to you to get your help. One of the things that I do want to mention is sort of how do drugs fit into our society? So there are sort of three predominant views. One is that drugs are illegal. People who use drugs are morally corrupt. They have no willpower. There's just something wrong with them. I just wanted to point out a couple of quick things, and these are small and they're old because it's hard to get this data. The one up there, Nixon launches the war on drugs, that's the prison population that happened in the US. And remember also, layered on top of this was that it became a for-profit jail system in the US as well. So the more people they could throw in jail, the better. But what you do know is that on that rise that goes up, you can be very sure that the vast majority of those people were people of color, because we see that all the time. Poor people are the easiest people to catch, for one thing, but also there was some targeted work going on. Down below, when we talk about drug strategies here, this is from 2004, 2005, because it's hard to get these numbers. But when they talk about the funding for a drug strategy, this is actually how it's broken out. 73% at that time went towards enforcement. Harm reduction got 3%, treatment 14%, and prevention 3%. When the next government came in, the Harper government, they removed that 3% for harm reduction. It's difficult. Okay, regulation. A regulation side that says, look, if we just regulate substances, we're going to be much better. So the Law Enforcement Action Partnership, which is an international group of lawyers, judges, police officers, etc., sort of in that whole world, they have a really great story around this. And part of it is that, we have alcohol in our society. We know that it can be very dangerous, actually. So we can put in rules to make it as safe as possible. We can put in age limits. We can put in drinking and driving laws. We can put in server laws. When you buy a bottle of wine, you know exactly what the alcohol percentage content is, right? Because it's all regulated. But as soon as a substance is illegal, you have no control anymore. There is nothing that you can do to make that safer. All you can do is arrest. And so what we end up with then is who sets the rules then? The folks who are selling the drugs. They can say how old you can be, where you can be, how much you can use. Does it, and in my mind, it just makes sense that we actually think about regulating. Drug dealers don't check ID, protect our kids. Harm reduction is really looking at health and safety and trying to put this issue into one of health rather than in criminality. And I'm going to show you two posters right now. One is an abstinence-based and one is a harm reduction-based. And I find this upsetting. The one on the right is the one that Alberta Health Services put out when fentanyl became more obvious. It's never going to be you until it is. Had I lost a child to a drug overdose and I walked around a corner and saw that, I would be gutted. I just can't. It doesn't do much. This one, we love you, be safe, carry naloxone. That's a harm reduction kind of messaging. This is from the Canadian Association of People Who Use Drugs. It conveys concern. It conveys, here's something you can do. Be safe. So that's sort of the difference between the two kinds of marketing. And, oh God, there's lots of misinformation, lack of science, abundance of drug hysteria, so then there's also a number of myths that go on. Fentanyl is going to cause an OD by touching it or being close to it. No. It doesn't do that. It doesn't cross through the skin that way. You can get fentanyl patches, but they are chemically altered to make that happen. And so, what I tell my team is, like, if you see a pile of powder, don't stick your finger in it and lick it. Like, that's silly. But it's a commodity. People don't leave piles of fentanyl laying around, right? It's worth something. And what you tend to see, too, is a lot, and I think that it is because they have been trained incorrectly. I might be wrong, but that's what I think is happening, is often you will see videos where someone in a uniform comes across some white powder, suddenly they're and they get all down, and down they go, and their friends swoop in, and they give them naloxone, and they cart them off to the hospital. Typically, they get increased breathing, they get lightheaded, they report that. But those are not symptoms of a fentanyl overdose. A fentanyl overdose, your breathing would slow, your head might go down, and you would become unconscious, right? I think these are panic attacks, quite honestly. And I think that they have been trained to be afraid, is what I think is happening. Didn't get HIV from a needle on the street. Nope, never happened. There was 2 cases of hepatitis C where that happened, and I see Stan came in, and he might correct me on this, which I would appreciate, but when you look at the AIDS map, the last 2 times, hepatitis C was possibly transmitted in Spain in 2005, but it's not common. A needle on the street, while it's distressing, is not going to make you sick. Everyone who uses illegal substances are addicted and need treatment. No, I think I've addressed that. Drug busts by the police will help. There's just this week been a couple of big news stories. Hey, look at all the drugs we got. The problem with that is that opens up the market for new dealers because it's a very lucrative market because it's illegal. And so it actually doesn't help, and studies have shown this. Studies recently, just this last year also, I think it was in Ohio, but they showed that overdose deaths went up after a large drug bust because new stuff comes into town that people aren't used to. They don't have their regular supply. That it's an opioid crisis. Oh, this drives me wild. It's not an opioid crisis. Opioids are necessary in some cases for people, right? If you're in the hospital and they give you opioids, it's because that's what's going to help you. But this blanketing that opioids are the problem or not is not true. It's a drug poisoning crisis. It's a drug policy crisis. It's a death crisis for sure. And it's funny, these are on the Edmonton bus stops, and opioid addiction kills. Bad opioid addiction can kill. And I'm not saying that it doesn't. However, in my experience, there were people that were using opioids for 45 or 50 years out on the street when we had a stable supply. They were okay. Without some thought, that comment is probably not accurate. My preference on bus stops would be that we would say, the drug supply is toxic. Here's where you can get help. Carry naloxone. Please don't use alone. Have some of those kind of messages. But anyway, that drugs are the problem. No, I would say our policy is the problem. And then that drugs create zombies. Honestly, you see this all the time. Look at these are all headlines from all over. Trank, the new zombie drug. How Spice, the zombie drug, is devastating communities. Flakka, the zombie drug. Facts about crocodile, the zombie drug. Zombie apocalypse in Saskatchewan. Don't go there. Legal weed is turning New York workers into zombies. Honest to God, everything from pot is considered a zombie drug. No, it's that drug war thinking. No one's saying alcohol's turning people into zombies. In terms of environmental impacts, this is actually taking on more and more of a focus these days in my world in terms of looking at what is we obviously have a climate crisis. We obviously know some of the causes of that crisis. Criminalized drugs, it's very lucrative, and especially for people who don't have other means, they will go to selling them. There is evidence of mass deforestation as large-scale producers take land and produce the product. International drug policies are driving environmental destruction, violence, and organized crime in many countries with hugely valuable and threatened ecosystems, including the Amazon and other tropical forests. Drug prohibition is a key driver of organized crime, corruption, and state capture in ecologically fragile regions. Addressing the climate emergency requires urgent coordinated action by environmental and drug policy movements to replace prohibition with regulation that supports people and planet. It's just so important to say that. If we had better planning globally, we wouldn't be in this mess that we're in, which I'm speaking to the Parkland Institute. You guys know that. So I'll just let you know what our program does. And we have 63 satellite sites around the city. We do have injection and inhalation supplies. We do core work, and then we have a special substance use and addiction program outreach team. We do overdose prevention and post-overdose response. So we're in the downtown core, in the general public, through the LRT, Downtown Mall and Pedways, and the Milner Library, and the Churchill Square. Also a data analyst. And my one little point of pride is that we did the first naloxone program in Canada in 2005 here in Edmonton in our program, and no one else started for 12 years. So we were very happy to do that. We do a lot around STIs, because yay, we were also in a syphilis epidemic. Yay, syphilis. All right. Testing and treatment for Edmonton and surrounding communities. Pregnancy support. There was no one more vilified in this world, I don't think, than a pregnant woman who uses substances. because no one asks why, and no one looks at how to help her. Our saying is always, we're not going to have a healthy baby if we don't have a healthy mom. So let's work on mom. Let's see what we can do. And I love it because our team, all of our teams, are made up of a combination of a person with lived experience, and in the HER program case, we have 4 outreach workers with lived experience, lived and living experience, 2 nurses, and a social worker, and they all work together. And the mentoring and the support that especially the women who've been there, done that, can give is amazing. We do general nursing stuff. And I have to say right now, we're in a situation where we have disaster zone kind of illnesses. So already we've got the COVID, influenza, STIs. We have Shigella, which is not typical. If people were housed, this would not be the issue that we're in. Bartonella, which is coming off of body lice, and body lice shouldn't be happening. A shower will do it, will help remove that, but people just don't have access to showers anymore. We're seeing now some cutaneous diphtheria, lots of trauma, chronic illnesses, and then we're also doing immunizations and screening and testing. We had an overdose prevention site, which is an supervised consumption site that was shut down out of Boyle Street. We're hoping to open one in the White Avenue area as we're watching and tracking those numbers and trying to make a connecting point for people. We also have remote nurses, so a number of locations where our nurses are, which I was really kind of happy because some organizations said, you know what, we've had other nurses who don't quite get it, and so your crew understands the population. And then we're involved in lots of research projects. We recently had to move to a new location because Boyle Street had to move very quickly in September, and unfortunately we're in a spot where we're not allowed to see clients, and so our whole work now has turned entirely to outreach, which is going to be tougher, as the weather cools down. We're lucky right now, but it's going to get cooler. And so one of the things I'm trying to do is to get a nursing van. I don't know, our nurses are going into these tents, where someone has a propane tank, which is a little unsafe, trying to do stuff in the cold, and it's just going to get worse. It'd be way better if we can come up close and have them come into a van where we can actually sit and have a conversation. So other solutions. The one that I do want to mention in particular is the greater involvement of people who use substances. I think there's lots of well-meaning people out there, but unless we're actually talking to the people who are impacted day in and day out by the mess that we're in right now, we're not. If we assume that we know what they need, then we're being very paternalistic and colonial. We need to bring people into the fold as equals to have those conversations and to act on them. Obviously, we talked about drug checking, increased overdose prevention site, decriminalization, addressing the issues of homelessness, poverty, pain, racism, and othering. This is so critical. I think people, when they hear the term regulating drugs, does that mean anyone can get anything at any time? No. One of the hats that I wear is that I'm the chair of the Canadian Drug Policy Coalition, and we've done a lot of work around looking at what would regulation look like. So what we do is understand that different drugs have different risks, and so they need different rules for each one. But keeping them all blanketed illegal is not likely going to help. There have been lots of examples around the world where people have either decriminalized or regulated certain drugs, and it's not become so much of a problem. So you can have an unregulated criminal market. The higher you go on this U, the more dangerous something is. So you can have an unregulated criminal market that's incredibly dangerous, and that's exactly where we're at right now. I cannot imagine it being even more dangerous, but it might be. But you can also have an unregulated legal market that's dangerous, where you take your son or your grandchild into 7-Eleven and he picks up some methamphetamine and some chips and a pop, and you grab some heroin and no, that's not what we're saying. No, that would be stupid. We are saying there are different ways of approaching this, and we need to think broadly and think outside the box in order to be able to do that. What we want to get is down in the middle there, where it's less dangerous. Nothing is going to be danger-free. Our alcohol supply is not danger-free, but we're doing the best we can. If you've not seen Supervised Consumption Services, that was our SCS that was at Boyle Street. It is not a party room. It's not a big whoop-de-doo time. It is actually probably the calmest place in the whole building. When people use drugs in that setting, there's something called drug set and setting, and it's a long thing, but more than one thing impacts on how a drug is going to affect you. And when people feel safe and warm and welcomed and supported, their response to their drugs are actually markedly different. And I saw more good things happen out of that space than I've ever seen in all of my years downtown. And then the other is just a note from Guy Felicella also pointing out some of the hypocrisy that we see. I guess now we'll just see if there's any questions. Thank you.
So Heather and Marliss, thank you so much. It's a lot of information to take in. In saying that, we are going to take some questions from the floor.
I wonder if you could comment perhaps on your relationship with the provincial government, particularly the Minister of Mental Health and Addictions, perhaps over time. Is it improved perhaps or gotten worse?
I guess I would have to say that I have no relationship with the current minister. I have in the past. Actually, I have to say that, I've been around forever, and we worked with the progressive conservative governments, and they were very, very supportive, actually, of the work that we did. And when the NDP came in, that was just at the start of the drug poisoning crisis, and so then they put in a number of things. But currently, I would say we have no relationship.
I was wondering if you could comment on the so-called recovery programs, because, of course, what this government says is that harm reduction, well, maybe we can allow a little bit of it, but the real thing is recovery. But what I learned over the last year because of a family incident was that the so-called recovery programs that exist, are almost exclusively the 12-step stuff, which doesn't really work for people who aren't super religious. B, don't seem to deal with anything to do with people's lives. It seem to involve a certain number of rackets, that there's kind of multinational corporations involved in making a lot of money off this stuff. What would real recovery programs look like, I guess, is my question.
Marliss made a very good point, which is that people who work in harm reduction would support residential treatment programs or recovery programs as well as harm reduction, and that sometimes what's happened is that there's been this a very huge dichotomy in terms of people saying that you have to be one or the other. But I think that most of us that work with people who use drugs recognize that some of those programs may be effective for some individuals, and for other people, they may decide to take a different approach. And that we have to really try to keep an open mind and support people where they're at in terms of what they feel is beneficial to them. One of the memories that I have of going to a conference, actually I think it was at the Stimulus conference about 5 or 6 years ago, I went up to a table and I spoke to a woman who was there representing 5 residential treatment programs. And at that time, I asked her about methadone and Suboxone for people who were in their residential treatment program. She was very clear with me. She represented 5 different residential treatment programs in BC and Alberta, and she was clear with me. She said, we either don't allow people to come in on methadone, or if they do come in on methadone, then we will try to taper them off as quickly as possible. That was 5 years ago, and I think things have changed a lot in terms of residential treatment programs, supporting people to use some of the medications that we've talked about, opioid agonist treatment. But people need to open up their thoughts and their minds and be able to accept different types of services and different types of supports that are available.
I think Heather hit it on the head. I mean, we have this idea that treatment is one thing, and I don't want to discount there are lots of people who have gone through 12-step programs that have done really well in them. And absolutely, if that's what you want and that's what works for you, then I'm very happy for you. But we can't keep it such a limited response. I think we're looking at a broad scale, and we have to ask people, what would you need to not use drugs? Like, what would help you? And have those options available. But there is very much, that it is difficult. Certainly some are faith-based, some are men only, some are, far away, so it's hard for someone to get to. So, I guess we'll see over the next few years. But I think the idea that everyone who's used an illegal drug has to go to recovery is wrong. It would be like saying everyone in this room who has drank alcohol is addicted, and you need to go to treatment, because that's what we're saying. And potentially forcing people into that at some point. So I would like us to have a broader conversation than what we have currently.
Hi, I work in rural home care. I just want to know if there's any legislation or anything to make the dispensing of some of these medications a little bit more accountable. I work with palliative clients, and I've seen horrendous amounts of fentanyl come out of hospitals, horrendous amounts of drugs come out of pharmacy, and no accountability after the person has passed away as to what's happened to those medications. And I'm talking like we've emptied the stock of fentanyl in a rural hospital for one patient over a weekend that died right away, and I don't know what happened to that medication. I have brought it forward to my management. I have brought it forward to my pharmacy teams, but there's been no answers and there's no accountability. And if all those drugs are coming out of Alberta Health Services onto the street, how is that harm reduction?
My response to that would be, and you're going to hate it. Okay, so just right now, you're going to hate me. I know that. So first of all, my sister was in the same case. When she was dying of cancer, we had all kinds of opioids in the house, and nobody came and got them afterwards. I actually tried to put our dog down with them, and it doesn't work, just so you know. I won't tell you that story, but anyway. Doesn't work. Pharmaceutical grade fentanyl, I think probably there should be some way to get those back, but that's not the problem that we're seeing. Quite honestly, if I had the choice between the toxic soup that someone has right now and a prescription, I would say, take the prescription, you're less likely to die. That's not likely a popular perspective, but what I'm seeing and what we're seeing in drug analysis reports are everything in what people are buying, and it speaks to their level of desperation in many ways. I agree with you that, certainly take the meds away from me who tries to do something that didn't work, right? Dispose of them appropriately. But that's not the problem that we're seeing. We're not seeing pills on the street. I actually wish we were, because I was there when we were seeing OxyContin, and the life was way better at that point for people. I think it comes to kind of our moral outrage and, are we just upset that people are using certain drugs? And I guess the question for me is always if someone's not hurting anyone and it's not causing a problem, why are we outraged? Anyway.
So in our union, we have addiction counselors and mental health therapists that are helping, but we also in this province have private and public treatment centers. Our people aren't regulated. So I'm not sure how much of the treatment centers you've been in and you've seen how the staff are working and this and that and what levels of staff they have. But is there a concern that we're going to have very underqualified people helping addiction clients and mental health clients because we don't have healthcare professionals that are regulated to do the work and have been doing it for 25 years?
I think that this is an issue that is we're just starting to scratch the surface at the moment in terms of regulation of residential treatment programs and oversight of the services that are provided. It's absolutely an area that needs to be explored more, and the government needs to step in and have more oversight in terms of the expertise of the people who are working there, as well as ensuring that the treatment that is provided is evidence-based. So thank you for bringing that up.
We know that 1 million Canadians, 1/35 of the population, is at risk from toxic drug supply. So what we're talking about is a mighty river of drugs. Well, there's got to be a mighty lake somewhere that's feeding this mighty river of drugs that are coming into Canada. What is the origin of that river? And what are we doing about it?
So a couple of thoughts come to my mind. One is that I just saw a report this week around the large amount of fentanyl that's being produced within Canada. We can't always say it's from somewhere else. If it's lucrative, someone will figure out how to do it. But again, I'm going to come back to, I'm not sure just getting rid of the drug is going to solve the problem on why people are using these substances to begin with. I think we need to address those issues. Think really upstream on this one. If some of our folks that we see in my program could have a place and have some supports and have some medication for their mental health issues and have food, and actually get some sleep, their substance use would go way down. It doesn't seem hard to me, but I'm also, even though I'm old and grouchy, I still have like glimmers of hope in my life.
My question is maybe more at a local micro level. I live in a neighborhood where there's an increased perception of public drug use that's linked to an increased perception of tents or the presence of a supportive housing unit that's been built in our neighborhood. I'm in a position of having to do a lot of community educating about harm reduction and lots of other things. Can you share a story or tell an example where a community has done a really good job of working with the drug users in that community and the service providers in that community to make everyone feel safe? Because I think it's just like there's so much fear and misinformation and misperceptions about drug users.
I think somehow drugs and tents have become connected in a way that we can't disentangle that right now. It's very, very frustrating. I think it's understanding also some of the things. People who use illegal drugs don't want to be obvious, and they don't actually want to be causing problems. They're using a substance for a reason. Now, where I've heard of communities doing better is actually where we have staff that live in those communities who actually go out and check on the people in the tents and take them naloxone kits and try and see if they need anything. There's an idea that poor equals unsafe, and I think one of the questions that Boyle Street's been doing, they have this group called Boyle Street Academy of Learning, and Academy of Understanding, sorry, I really love it, because they'll go in and talk to groups, and one of the things that they will say is, you need to ask yourself, am I uncomfortable or am I in danger? Because those are two different things, and you need to respond differently to each. And if it's that you're uncomfortable, you need to learn a bit more, talk a bit more, talk to people who know, like yourself. If you're in danger, then of course you respond. But I think in many cases, people's discomfort is being taken as in danger. And I don't have a good solution to that. I wish I did. Do you?
I think just on a personal level, myself, when I started volunteering with the Streetworks van back in 2018, I got to understand the needs of the community members a lot better, and it was just a major eye-opening experience for me. I've also volunteered with Garneau Strathcona Food Security, which is a food bank, for the last 10 or 11 years. And on a personal note, when you start to interact and meet people who may be at a different socioeconomic level than yourself, but you start to realize that they still have many of the same types of interests and things that they want to talk about, and life challenges that you and I have. And once you start to get to know people on a personal level, it really changes your perception. And so maybe within your community, there may be ways or opportunities for people to start to volunteer, to get to know people who are affected by some of these challenges. That might make a difference as well, too.
I've been a nurse downtown now, registered nurse downtown, for 28 years, and I had a lovely nursing career prior to this. What I get from the crowd that we see is real concern, mutual respect, lots of caring. I get thanked more in this job than I ever did in any of my other jobs. And it's not about that, but I think it's more this idea that those people are subhuman is just so wrong. But it's hard to break the narrative, especially if there's a driver for a narrative that says these people are bad.